The volume of gas in our lungs at any given moment depends on the mechanics of our lung tissue, our chest wall, and our respiratory muscles. Now, if there's a problem with any of these particular things, it's going to affect the volume of gas in our lungs. Therefore, if somebody has a respiratory disease, we can measure these lung volumes and it can be an indication to tell us what type of respiratory disease or disorder an individual may have. So in order for us to discuss this, we need to talk about the different types of lung volumes. When you add these volumes together, the types of lung capacities you get, and then the two major types of lung diseases, which are restrictive and obstructive. So first thing we need to talk about are the 4 different types of lung volumes that you need to know. So the first one is that of tidal volume. So tidal volume, TV, is basically, it's all in the name, right? The tide. The tide is that slow ebbs and flows of the water coming in and out. It's very slow, going in and out, and that's our quiet breath. Small breath in, small breath out. The type of breathing that we do most often throughout the day. That small breath in and out is around about 500 milliliters, so half a litre. And that's our tidal volume. Now, we can bring air in on top of that tidal volume, and that's our inspiratory reserve volume. So forcefully inhaling air is our inspiratory reserve volume, our IRV. Now that forceful inhalation or inspiration of air on top of that tidal volume is around about 2.5 litres. Now these values I'm giving you are for a healthy male 70 kilos such as myself. Now we can forcefully exhale air on top of that tidal volume, right? So we have that small quiet breath out of half a litre, but then we can forcefully exhale more air until it feels as though there's nothing left. That is our expiratory reserve volume. Also known as our ERV. And that is around about 1.5 litres. Now, you would think that that's everything. But in actual fact, once we do that expiratory reserve volume, and we feel as though there's nothing left in our lungs, there is actually around about 1.5 litres left in our lungs, and that's what we call our residual volume. This is air or gas that we cannot forcefully exhale. Also known as our RV. So air that we can't forcefully exhale on top of our expiratory reserve volume. Now this is around about 1.5 litres as well. So these are the 4 volumes you need to know. Now you can add certain combinations of these volumes and that gives you lung capacities. And I'll show you how we can do this. A great way to demonstrate this visually is by drawing it up like this. Here is our tidal volume, which I said was around about half a litre. And I said on top of our tidal volume we can forcefully inhale air of around about 2.5 litres. And that's our inspiratory reserve volume. I also said on top of our tidal volume that we breathe out, we've got our expiratory reserve volume, which is around about 1.5 litres. And I also said that there's going to be air that we can't forcefully exhale called our reserve volume, which is also around about 1.5 litres. So here are our 4 volumes. All right, we can add some of these volumes and get capacities. So let's take a look. We can add the inspiratory reserve volume, tidal volume, and expiratory reserve volume. And if you think about it, these are all volumes that we can play around with. I can consciously have a breath in and breath out, and I can forcefully breathe in and forcefully breathe out. This is what we call our vital capacity. Our VC, our vital capacity, because it's what's required for life. Now, we can also add the inspiratory reserve volume and tidal volume together. And this is what we call our inspiratory capacity So our IC. And we've also got the amount of air that we can forcefully exhale and our reserve volume, which we call our functional residual volume. So our FRV. So these are our capacities. Now the last capacity is everything together, right? And that's our total lung capacity. That's everything our lungs can hold. Our TLC. All right. Now, when we look at certain respiratory diseases, like obstructive diseases or restrictive diseases, they're the two major types, they can play around with each of these volumes or capacities, and I want to show you how. So, what we're going to do is wipe off the capacities. What we've drawn up here is, for lack of a better term, a normal lung volume and capacity readout. Now, if we've got something like a restrictive disease, now a restrictive respiratory disease is something like pulmonary fibrosis. So fibrosis is like scar tissue that's been laid down in the lungs. Now scar tissue isn't elastic. We know our lungs are elastic. We breathe in, it stretches, we relax, it recoils. But restrictive diseases, they limit the lungs' compliancy, their ability to stretch. So that means the amount of air that you can breathe in is limited, it's reduced, which also means the amount of air that you breathe out is limited to the same degree. So what you're going to find with restrictive disorders is that every one of these volumes is reduced. And so we can just draw it up with a small tidal volume. We can draw it up with a small expiratory reserve volume. We can draw it up with a small reserve volume. We can draw it up with a small inspiratory reserve volume. And so what that means is, while all the volumes are reduced, it also means the total lung capacity, the TLC, is reduced as well. So that's a respiratory disorder. Now when we look at an obstructive disorder, and there's many different types of obstructive disorders, so if you think of chronic obstructive pulmonary diseases like emphysema and chronic bronchitis, they fit within this particular category. In an obstructive disorder, it's not that the lung tissue is no longer stretchy, so reduction in compliancy. In actual fact, there's some sort of obstruction in the airways itself. Now this could be mucus, for example. It could be a narrowing of the airways. But what's important here is this. In an obstructive disease, when you breathe in, everything opens up, which means if you have a hollow tube which has a mucus plug in it, for example, when you go to inhale, that hollow tube gets larger, which means that mucus plug obstructs less of it. So inspiration in obstructive disorders aren't necessarily limited. So they're around about normal. But the problem is when you go to expire and breathe out, that tube narrows again, and then that mucus plug, for example, will obstruct and the gases cannot leave, which means gases remain inside the lung tissue. All right, so what does that therefore mean? How do we translate this on something like this graph? Well, your tidal volume is going to basically be normal. Small breath in, small breath out. These obstructions don't necessarily alter that. Now, our inspiratory reserve volume, I said when you breathe in, the airways open up and it's not limited. So inspiratory reserve volume tends to be relatively normal in an obstructive disorder. But when you expire, as the airways narrow, you can't breathe out that expiratory reserve volume. So the expiratory reserve volume is reduced. But what that means is, think about it. You breathe in, you breathe out. Breathe in, breathe out, all right? If you're breathing in all this air or gas and you can't breathe it out, it now sits as a residual volume. So you've got this really big residual volume. Now what that means overall is that you have an increase in total lung capacity and an increase in residual volume and a decrease in expiratory reserve volume. Now this is important. This is really important because when you look at individuals with emphysema, they get barrel chests, and they get barrel chests because they keep accumulating this residual volume because they breathe in but they can't breathe it out. So this is why it's important to understand the lung capacities and lung volumes when it comes to restrictive and obstructive disorders.
Obstructive versus restrictive respiratory diseases are two of the most common categories of respiratory diseases you'll come across, excluding infectious respiratory diseases. So we're going to focus on what are restrictive and what are obstructive respiratory diseases, and then compare the differences between the two. So what we need to begin with is what basically happens in a healthy lung. So what I'm going to draw up first of all is a healthy lung, oversimplified. So we have a healthy lung, we have some nice, open, patent airways. And we know that our lungs contain a huge amount of what we call elastic tissue, because we know that our lungs need to be able to stretch out and also recall back together, as though it's filled with a huge amount of elastic bands. So we have all this elastic tissue within our lungs. Now importantly, this elastic tissue is attached to our airways, and this is important because when this elastic tissue stretches out, it needs to stretch open those airways with it. So that means when you take a nice big deep breath in and that elastic tissue stretches, it's going to pull open those airways, and then when it relaxes, they're going to come back together. Now, we know that when our lungs need to expand, we need to do this by contracting predominantly what we call the diaphragm, which is the muscle that sits underneath the lungs, and also the external intercostal muscles, which are the muscles that sit between our ribs. Now, before we talk about that, you need to know that the lung itself has some membranes associated with it. There's a membrane that's most adherent to the lung tissue itself, and this membrane is called the visceral pleura. And there's also another membrane that just sits a little bit away from this, further away from the lung tissue, but closer to the rib cage, or the thoracic cavity, I should say. And this is called the parietal pleura. So there's two membranes, visceral pleura and parietal pleura, and in between there's a fluid that's released. And this fluid, what happens is this fluid allows for some lubrication to occur, but also there's a negative pressure inside of this little cavity here called the pleural cavity. Now, this parietal pleura is going to be adherent to the thoracic wall. So what we're going to draw up now is some ribs. Now again, I'm oversimplifying this. These ribs are going to be a little bit closer than what I'm drawing. And also between those ribs, you're going to have some muscle, which is going to be the external and internal intercostal muscles. Now, I said there's going to be a diaphragm, so let's draw the diaphragm in, which is that nice skeletal muscle that sits underneath the lungs itself. So you know that when we need to take a breath in, what happens is, because we have a negative pressure in this pleural cavity, it's like a vacuum. What happens? They stick together. And because they stick together, whatever this parietal pleura is attached to, the visceral pleura will move with it as well. So because this parietal pleura is going to be adherent to the diaphragm and also to the thoracic wall, if the diaphragm moves down, which it does when it contracts, it's going to pull the lung tissue with it. And when the external intercostal muscles contract and the rib cage comes up and out like this, it's going to pull the lungs with it. So that's what happens when we take a breath in. Diaphragm goes down, external intercostals pull outwards, and the entire thoracic volume increases. And when that entire thoracic volume increases, it becomes a little bit negative in here and air rushes in. Now, what tells these external intercostal muscles and the diaphragm to contract? Well, it has to be some sort of nervous innervation. Where does this nervous innervation come from? Well, it has to come from the central nervous system. So let's draw up very quickly the brain, I'll draw it the other way. You're going to have the brain, the cerebellum, you're going to have the midbrain, pons and medulla of the brainstem, then we're going to have the spinal cord, so yes, it's an oversimplified version. Now, when it comes to respiration, the most important area of the central nervous system is the brainstem. Specifically, it's going to be so remember you have the midbrain, the pons and the medulla, which make up the brainstem. The respiratory center is made up of the medulla and the pons. Okay, so the medulla and the pons are the most important aspects of the brainstem for respiration. We're not going to go into the specifics of it, but just know that there's neurons there that help you breathe, and that these neurons are going to talk to neurons of the cervical plexus and of the thoracic nerves. So as we move down, we're going to go to the cervical region of the spinal cord, and we're going to talk to three aspects. So C3, C4, C5. C3, C4, C5. Now these neurons what they do is they innervate the diaphragm. So neurons from C3, C4, C5 come and innervate the diaphragm, which means they tell the diaphragm to contract, which means it pulls down and that air comes in. So inspiration. This nerve, as you know, is called the phrenic nerve. C3, C4, C5. We've also got some coming out of the thoracic aspect of the spinal cord. Now I'm not going to draw the adequate number, but I'm just going to draw some just to highlight to you. And these are going to innervate the external intercostals, which then tells them to contract, and therefore bringing the rib cage up and out, and again allowing it to come in. So this is part of the normal anatomy for the respiratory system. Why am I telling you this? What does this have to do with restrictive and obstructive diseases? Well, so remember, lungs need to expand. That's what needs to happen normally. Now, they need to be stretchy, so it's called stretchability, but we don't call it clinically, we don't refer to it as a stretchability. Stretchability we call compliancy. So let's just write that down. Compliancy is the stretchability of the lungs. How stretchy the lungs are. Now, if it's very compliant, the lungs can stretch out quite easily. And remember, we need it to have a nice elastic recoil as well. Now, if something happens, doesn't matter if it starts at the central nervous system, doesn't matter if it comes from the peripheral nervous system, doesn't matter whether it comes from the musculoskeletal system, doesn't matter if it comes from within the tissue of the lungs itself. If something happens to restrict the expandability of the lungs, that is called a restrictive disease. So restrictive disease limits lung expansion. Okay? So restrictive diseases limit lung expansion. And as you can see, that can come from the central nervous system, peripheral nervous system, musculoskeletal system, or within the tissue itself, also known as within the parenchyma of the lung. So, if we were to look at all the causes of restrictive diseases outside of the lung itself, that's known as extrinsic restrictive diseases. They're known as extrinsic restrictive diseases, also known as extrapulmonary diseases. Okay, extrapulmonary restrictive diseases. So if it comes from the central nervous system, an example of this could be amyotrophic lateral sclerosis, ALS. In the States, it's known as Lou Gehrig's disease. And this is going to be neuronal degeneration of the central nervous system, which can affect, obviously, the neurons that innervate the external intercostal muscles and the diaphragm. We can have issues in which we have damage to these nerves, either in the spinal cord itself or the peripheral nervous system, and this can happen through spinal cord injury, for example. You may get depression of activity of these neurons within the central nervous system, and this comes from morphine, for example. We know depresses the respiratory function and can depress patients' respiration as well. What else can we have? Well, we can have issues with the muscles of the respiratory system, and this is what was common in polio, hence why individuals who had polio needed to breathe inside of what was called an iron lung to sort of recapitulate what happens normally when lungs expand. That's what that machine would do, expand the chest cavity for you. Or we can have issues with the bones or skeleton of the respiratory system. What's the most common aspects there? Well, we've got the ribs and we've got the spine. Why the spine? Because the ribs are attached to the spine. So if you have a broken rib, you know it's very difficult to breathe, or at least it's quite painful to breathe. Or if you have a problem with your spine, meaning you have some sort of kyphosis or scoliosis or lordosis, which are abnormalities of the curvature of the spine, well, if the spine's going to be curved, whether it's going to be lateral curvature abnormalities or anterior posterior curvature abnormalities, this is going to alter the way that the ribs are positioned and also alter the way that you can breathe. So these could be classified as extrinsic restrictive pulmonary diseases. Okay? I want to focus on intrinsic restrictive pulmonary diseases. So what's happening inside the lung tissue itself? So in order to do that, let's get rid of some of the stuff we've put up at the moment. And we're going to focus just on the lung tissue itself. Now, as you can see, we've drawn up a nice healthy lung here. We have nice patent, which means open airways. We have a lot of elastic tissue, which you can see here. This elastic tissue allows for the lungs to be compliant, which means stretch out, but also very importantly, allows for the lungs to recoil. Okay, so that's very important. Allows for the lungs to recoil back in. Now, when you breathe normally, I'm sure you've already had a look at what we call pulmonary function tests. So that's where you breathe into a machine and it looks at your tidal volume, which is your normal breath in, normal breath out, your inspiratory reserve volume, how much breath you can take in when you forcefully inhale, and your expiratory reserve volume, how much air you can forcefully exhale. And you also know that you cannot ever exhale every single bit of gas inside of your lungs. That's important because one, don't want your lungs to collapse. Two, even when you want to exhale all that air out, there needs to be some gas remaining for gas exchange with the blood. Okay? So, nice, happy, healthy lung. Let's just draw up a nice pulmonary function test just to represent what's going on. Well, like I said, you're going to take a nice tidal breath in and out, and in and out, and in. And then you know that after a normal breath in, you can breathe even more air in. This is called the inspiratory reserve volume. And you know that you can breathe that out. And you can try and breathe out as much of it as you can, called the expiratory reserve volume. And then you go back and you take another nice tidal breath in, out, in. Okay, so what we've got, a couple of things we need to highlight. First thing we need to highlight is, like I said, this is our tidal volume, TV, it's often referred to as. Breath in, breath out. We've got the inspiratory reserve volume, the IRV, how much air we can breathe in on top of a normal breath in. The expiratory reserve volume, how much air we can breathe out on top of a normal breath out. And like I said, you can't breathe all your air out. You've got a residual volume. Now that means that at the bottom of this residual volume is going to be 0 liters. This is when your lungs do not contain any air at all. So let's just draw a nice line because I want to compare this between restrictive and obstructive diseases. So let's draw a nice line across the entire board. Hopefully it's nice and straight for you. And like I said, this is going to represent 0 liters. Now, normal, nice, happy, healthy lung. When we look at intrinsic restrictive diseases, something has to happen inside the lung parenchyma itself to restrict the expandability of the lungs, right? Because that's what a restrictive disease is. Now, what can happen is this. If over time, so chronic exposure to irritants, some sort of particulates, some irritants to the lung tissue, it can damage the lung tissue and lead to scarring of the lung tissue. Now, this is called pulmonary fibrosis. pulmonary fibrosis, which literally means lung scarring. Now, because you're having irritation and you're having damage, you know that when some sort of inflammatory response occurs, that quite often damage to this tissue will lead to scarring, so more collagenous tissue, so more collagen fibers will be deposited. And so what you're going to get is more tissue being deposited. Let me leave that as a normal, happy, healthy lung, and I'll draw up a new lung up. I'm intentionally drawing it smaller, and I'll tell you why. Firstly, when we look at restrictive diseases, the airways are of normal size. I'll tell you why in a second. But like I said, you've got a greater amount of collagen deposited and sometimes even more elastic tissue, so it's very, very dense inside the lung tissue itself because of this pulmonary fibrosis. So more tissue is being deposited. Now, what does that mean? Well, think about it. If we think of the normal, happy, healthy lung as being, let's say, 10 rubber bands, let's write that down. Just write 10 rubber bands. If you had 10 rubber bands together and you were to stretch it open, it would have some sort of stretchability or compliancy to it. And then if you let go, it would have some level of elastic recoil to it. That's a normal, happy, healthy lung. You can think of the restrictive lung as having, let's say, 20 elastic bands or 20 rubber bands, however you like to refer to them as. What does that mean? Well, if you had 20, it's going to be a lot harder to stretch out because you've got more of them, but they'll have a very high degree of elastic recoil. So that means the compliancy is reduced, but the recoil is increased. Let's write that down. For restrictive diseases, compliancy is decreased and recoil has increased. So that's why the lung's smaller, because it's hard to stretch it out, but at rest it's quite tight. It's recoiled quite a large amount because of all these fibers that are deposited. Okay. Now, what do you think that means if we look at this pulmonary function test? Well, you're going to have a relatively normal tidal volume, but do you think you'll be able to forcefully inhale that inspiratory reserve volume as well as you can with a healthy lung? No, it's going to be very difficult. So you're going to have a reduced inspiratory reserve volume because it's hard to expand those lungs. If the inspiratory reserve volume is reduced, that means less air in. That also means less air can come out. So your expiratory reserve volume is reduced as well. Now, in addition to that, if the lungs at rest are smaller, there's going to be less air remaining in there that you can't expel, which means the reserve volume is also reduced. So if we were to draw this up, we would have a relatively normal tidal volume. The inspiratory reserve volume is going to be low, the expiratory reserve volume is going to be low, and the residual volume is going to be low. So you can see tidal volume's not too bad. Decreased expiratory reserve volume. Inspiratory reserve volume. Decreased expiratory reserve volume, and you can see decreased reserve volume. So we can write that up here. You have decreased inspiratory reserve volume, decreased expiratory reserve volume, decreased residual volume, and overall, if you look at total lung capacity, well, that's the total lung capacity there, you have decreased total lung capacity as well. This is what you commonly find in restrictive diseases. Let's look at obstructive diseases. How do they differ? Well, restrictive is some sort of difficulty in expanding the lung tissue. Obstructive is some sort of obstruction in the airways. So here are the airways. Now, there's a couple of common obstructive diseases you need to be aware of. These common obstructive diseases include asthma. That's one. Now in asthma, we're going to have a number of other videos available to you that discuss asthma and the following, so I'm going to be very quick in the way I describe it. Asthma is a reversible disease which involves narrowing of the airways. So what you find is that if you have a normal airway, in asthma, it's narrowed. Now, this narrowing of the airways is often due to hyperresponsiveness. Which means something that in somebody who doesn't have asthma wouldn't trigger any constriction of the airways would trigger it in an asthmatic patient. So hyperresponsiveness doesn't usually affect others, but only affects those individuals who have asthma. And it's a narrowing of those airways. And it can be due to a number of reasons. You can have extrinsic and intrinsic causes of asthma. Narrowing of the airways, hence it's an obstructive disease because it's obstructing the amount of air that can go in and out. Another common type is chronic bronchitis. And in chronic bronchitis, you have some sort of irritation, chronic irritation, that causes mucus hypersecretion. Mucus hypersecretion. So what does that mean? It means this irritation is causing more mucus to be secreted within the airways. And so what are you going to have? You're going to have your airway, and you're going to have mucus inside of that airway. And again, that mucus will plug these airways up and obstruct the airway, hence why chronic bronchitis is an obstructive pulmonary disease. The last one is emphysema. And emphysema, yes, you have some sort of obstruction within the airways, but what happens as well is that 80 to 90% of patients who have emphysema have a history of smoking. What happens with smoking is that these particulates, these chemicals that are coming into the airways, start to damage the lung tissue itself. And in addition to that, we have macrophages, remember, big eaters inside the lung tissue, which are trying their hardest to rid the lung tissue of these invading chemicals, these chemicals that shouldn't be in here. Now, they secrete proteases, which are enzymes that break down proteins, and elastases that break down the elastic tissue within the lungs as well. So what that means is, apart from obstructing the airways in emphysema, you also have the elastic tissue within this airway being eaten away as well. So what does that mean if I were to draw it up? If you were to remove some of this elastic tissue, think about what that means. Remember I said 10 elastic bands here, 20 elastic bands for restrictive. With obstructive, you can think of it as though there's only 5 elastic bands. That means it's a lot easier to stretch open, but the recoil isn't as great. So that means you have a high compliancy, but a poor elastic recoil, which is pretty much the opposite of the restrictive. So if we were to draw up a lung of somebody with an obstructive disease, the lung is going to be larger, and the airways are going to be smaller because it's an obstructive disease, and the elastic tissue is going to be reduced. Again, what does that mean? It means that when you pull on this lung tissue, it's going to be quite stretchy, just like you would with about 5 rubber bands or elastic bands. Opens up very easily, but doesn't snap back very well, which means that patients with obstructive diseases, particularly asthma, chronic bronchitis, emphysema, which we commonly refer to together as COPD, chronic obstructive pulmonary diseases, it means that they usually don't have a big issue with breathing in because it stretches very easily, but they have a big issue with breathing out. And it's very difficult to get all the air out of their lungs. So this means that breath in, breath out, they don't exhale as much as they should be able to exhale. And that means that, what do you think? their respiratory volume is going to get greater and greater. The amount of air that they can't breathe out increases and increases and increases. And this is commonly why you see some of these patients with a big barrel chest. Quite common in individuals with emphysema. So if we were to draw this up again, what you're going to find, and I have to rub this out a little bit because I'm going to go a little bit higher, is that I said the residual volume is higher. The tidal volume is going to be not too bad. The inspiratory reserve volume is going to be quite high. The expiratory reserve volume is going to be quite poor. And the residual volume is going to be quite high. So increased inspiratory reserve volume, increased reserve volume, decreased expiratory reserve volume. And what about the entire total lung capacity? Increased total lung capacity. So comparing compliancy and recall, might as well write it down. The compliancy for an obstructive disease is greater. The recall is reduced. Okay? And again, you have increased total lung capacity, increased inspiratory reserve volume, increased residual volume for somebody with an obstructive disease. Remember I said that this elastic tissue is attached to the airways? That means that when you expand a lung, the airways get larger, and then when you bring it back together, the airways get smaller. Think about what happens with an obstructive disease. I said that they can easily stretch their lungs out, which means the airways open up. But because there's reduced elastic tissue, not as much of this elastic tissue is attached to the airways as there should be, which means that when it comes back together, the thing that keeps these airways open and patent is their attachment to the elastic tissue, which means people with obstructive diseases, when they go to breathe out, the airways are likely to collapse, because the thing that keeps them open and patent is that elastic tissue, and there's not much there. So it's quite common that they have collapsing airways, which is one of the reasons why you see patients with emphysema breathing with pursed lips, because if they were to exhale too quickly, the airways can collapse. So they control the expiration through pursed lips. That's the difference between restrictive, just very basically the difference between restrictive pulmonary diseases and obstructive pulmonary diseases. So in this video, we're going to take a quick introductory look at ventilation-perfusion coupling. Now you may see it written in your textbooks as ventilation-perfusion matching, or VQ coupling, or VQ matching. It's all the same thing. Now, to put it into context, what are we referring to? We're basically referring to the events of gas exchange that happens at your alveoli with the blood flowing past your alveoli. Okay, that's what we're referring to. So that means, remember the 4 phases of breathing? You've got ventilation, air coming into and out of your lungs. You have external respiration, where gas is exchanged at your alveoli to the capillaries and vice versa. You have gas transport, where oxygen and carbon dioxide is transported through your circulatory system. And you have internal respiration, where gas is exchanged at the tissues of your body. Okay, so what we're referring to today is gas being exchanged at your alveoli with your blood that's going past, so your pulmonary blood supply. Firstly, let's go back and let's define ventilation and let's define perfusion. Okay, first thing is ventilation. Ventilation is the amount of gas that gets to your alveoli every minute that can participate in gas exchange. Okay, so simply put, ventilation is the amount of gas in your alveoli. That's ventilation, okay? For example, if I were to draw an alveoli up, it's the amount of gas coming in and out of this alveoli every minute. So that is ventilation. This gas, you know, wants to move across the respiratory membrane, and the oxygen wants to jump into the blood and the carbon dioxide wants to jump out of the blood, so it can be breathed out. That's ventilation. Perfusion is the amount of blood that moves past the alveoli every minute that can participate in gas exchange. So you have blood moving past, and this blood can either pick up oxygen or drop off carbon dioxide or do both. And this blood that's going past is what we refer to as perfusion. So perfusion is the amount of blood moving past alveoli that can also participate in gas exchange. Okay? So, that's the first point. We've now defined what we're referring to. Next thing is this. Why is it called coupling? It's called coupling or matching because we want there to be a near perfect match, meaning of the gas that comes into the alveoli, we want there to be enough blood to go past that can take that gas away or to give the carbon dioxide away. So let me give you a nice example. Let's just say we inspire some air and we have in that inspired air 100 units of oxygen. Okay? So we'll just say 100 units of oxygen, whatever that may mean. And let's just say of the blood that's going past, we have 100 carrier units of oxygen, so basically hemoglobin. But you know that one hemoglobin carries far more than one oxygen. But for simplicity's sake, let's just say that one carrier carries one oxygen. Now what you can see here is if we have 100 units of oxygen coming into the alveoli and 100 units, carrier units, coming past in the blood, this is a perfect match. It's 1 for 1. For every gas that jumps into the blood, we have a carrier molecule that can take it away. This is what we refer to as matching. And our lungs want this matching to be near perfect. Now in actual fact, if you have a look, you'll see that of the amount of gas that comes through, so for your ventilation per minute, you'll find that the amount of gas that comes in is around about 4.2 litres. Okay, and the amount of blood that moves past, which is your cardiac output, so the amount of blood moving past per minute is 5 litres. So if we do the ventilation-perfusion ratio, which is V over Q, so remember the V is ventilation and the Q is perfusion. If we have a look at this, what is it? The ventilation is 4.2. The perfusion is 5. If you have a look at that, which is 8.4 to 10, which is nearly 1 to 1. In actual fact, it's around about 0.8 instead of 1, okay? But it's close. So what you can see is there's a near match for the ventilated air compared to the blood that's perfusing past, okay? And your body wants to keep it like this. So let's talk about what happens when things go wrong. So let's just say there's some anatomical or functional issue in which ventilation drops, or let's just say what happens if perfusion were to drop. So let's have a look. First thing you need to be aware of is the amount or the partial pressure of gases, throwing stuff all over the place, the partial pressure of gases, not just in the atmosphere, but in your alveoli and in your blood. So let's first talk about partial pressures and what that truly refers to. Partial pressure. Well, in the atmosphere that we breathe, in the air that we breathe right now, there is a certain amount of pressure being forced upon us. Okay? And this is just the sum total of all the gases in this atmosphere pressing down on us. What are these gases? Well, these gases are nitrogen. These gases are oxygen. These gases are carbon dioxide. And there's some other trace gases that are there. So these are the main gases that we're breathing in right now and that are in the atmosphere. Now, the pressure on us right now is actually 760 millimeters of mercury. That's the amount of pressure. And your question may be, how come I'm not feeling this pressure? Well, you're born into it. So of course you're not going to feel it. You have 760 millimeters of mercury pressure placed upon you now, and it's the sum total of the individual gases. So, of all the gas, you'll find that about 78-79% is nitrogen. you'll find that around about 21% is oxygen. And you'll find around about 0.03% is carbon dioxide. So there's not much carbon dioxide in the air that we're breathing right now. Now, that means that if I were to take 79% of 760, I have the partial pressure of nitrogen in the atmosphere. Okay? And we would write that as P N2. And let's just see if we were to calculate that. The partial pressure would be around about 600 millimeters of mercury. Okay? If we were to calculate the partial pressure of oxygen in the atmosphere, 21% of 760 is around about the partial pressure of oxygen. It's around about 159 millimeters of mercury. If we were to calculate the partial pressure of carbon dioxide in the atmosphere, 0.03% of 760, you'll find that the partial pressure of carbon dioxide is around about 0.2 millimeters of mercury. Okay? So that means that outside in the air, so you know that nitrogen we don't need to worry about, so let's forget about that. I've spoken about in the lectures why we don't care about nitrogen. Firstly, it's an inert gas, so it doesn't really react very well, and there's no strong pressure gradient for it to dissolve within our blood or into our tissues, unless you're deep sea diving, and then the pressures change. But that's for another discussion. So, let's just say out in the atmosphere now, the atmospheric pressure is, for oxygen, 159, for carbon dioxide, 0.2. Now, we breathe that air in. That 159 millimeters of mercury comes into the lungs, that 0.2 millimeters of mercury carbon dioxide comes into our lungs, but the amount of gas, the partial pressure of these gases change. So what you'll find is by the time this gas reaches your lungs, that the partial pressure of oxygen is actually 100 millimeters of mercury. Okay? And because some of that oxygen is being mixed with water, because we're humidifying some of this air, and some of this oxygen is being lost via other means. So that partial pressure of oxygen drops. You'll also find the level of carbon dioxide. So the partial pressure of CO2 goes from being 0.2, goes all the way up to 40 millimeters of mercury. Why does it jump up so high? Well, because this blood going past continually throws carbon dioxide in here. So this alveoli is like a little chamber for CO2. CO2 being thrown in, so 0.2 coming in, but it's mixing with the higher CO2 that's coming from the blood. Okay? Now, next point is that the blood going past, this blood wants to pick up oxygen, so oxygen wants to go in this direction, okay? And carbon dioxide wants to go into the alveoli, so in this direction. Now, gases will only move down their pressure gradient, which means if oxygen is 100 millimeters of mercury in the alveoli, it must be something less in the pulmonary artery going past, and it is. So, partial pressure of oxygen in the pulmonary artery is 40 millimeters of mercury. Okay? Which means oxygen can jump in. Carbon dioxide, the partial pressure of CO2, well, is it going to be more or less in the blood? Has to be more because the CO2 wants to jump into the alveoli, go downhill. So the partial pressure in the blood is 45 millimeters of mercury. Now look at the differences. There is a difference for oxygen, 100 to 40, which is a 60 millimeter mercury difference. And from carbon dioxide, from the alveoli to the blood, is only a 5 millimeter of mercury difference. But did you know that the same amount of oxygen and CO2 gets exchanged? Now, you'd think, well, wouldn't there be more oxygen exchange than CO2 because of the pressure so much greater, that there's a stronger push behind oxygen compared to carbon dioxide? And the answer is yes, but remember, carbon dioxide is about 20 times more soluble in liquid than oxygen is. So carbon dioxide does not need much of a push to go across that respiratory membrane. Okay? Now, that's the first point. This is what happens normally, and you get this nice matching for the air that comes in, for the ventilation, it matches with the perfusion and everything's fine. But let's just say something's happened and a patient, a child comes in and they've inhaled a peanut and that peanut gets trapped and blocks an airway. Well, let's think about what happens. If this peanut comes in and blocks an airway, that means the ventilation is going to drop, right? Because it's blocked, no air can come in and no air can go out, so ventilation drops. Now, what happens in your body is, at your lungs specifically, is quite amazing, because when this drops, right, think about it, let's just say we had that 100 units of oxygen and the 100 units of blood going past to pick it up. Well, now that we've blocked it, this is going to drop. Let's just say this goes down to 10 units of oxygen. But we still have 100 units of blood going past. So what are we wasting? We are wasting the blood that's going past. Now this blood could be used elsewhere. This blood could be redirected to parts of the lung which are well ventilated, not poorly ventilated. So what the body does is, again, it wants to match. It wants to create this coupling. So I want you to think about, how could we create a match? If ventilation drops, how could we make perfusion match that? Well, we drop perfusion. We drop the amount of blood that goes past. How do we do that? Well, we vasoconstrict. So we tell this blood vessel to constrict. And if that happens, less blood goes past and it starts to match. Now the good thing about this, is that if you constrict this blood vessel, the blood gets pushed back, which means it gets redirected to other alveoli that are well ventilated. So perfect. So, how does this mechanism occur? If you have a drop in ventilation due to some sort of block at your alveoli, how do we get this constriction? Well, what you find is, when this alveoli is blocked, that means that this gas is trapped in a way. So it can't go in and out of the atmosphere, okay, or in and out of the alveoli and exchange with the atmosphere. So the level of oxygen that's in this alveoli can only go one place, and that's into the blood. So that means the concentration or partial pressure of oxygen drops, because it'll jump into the blood. What about CO2? Well, as the CO2 goes past, it's going downhill, it's trapped here, so CO2 will jump into the alveoli, so CO2 here will go up. What you'll find is a drop in ventilation equals a drop in the partial pressure of oxygen in the alveoli. Right? And what this results in is the drop in oxygen is what stimulates. It's the drop in oxygen that stimulates vasoconstriction. It's the oxygen that stimulates vasoconstriction. Okay, hopefully that makes sense. So it's starting to match. Now I want to talk about what happens if something blocks the blood flow going through. So dropping the perfusion. So let's have a look. So remove that. Get rid of the peanut. Airways are nice and clear. Let's keep this up here, but let's write it a bit neater. So let's make the statement that a drop in ventilation equals a drop in alveolar oxygen, which equals vasoconstriction, which equals a drop in perfusion. Okay? Now let's just say that this person, ventilation is fine, it's perfect, the airways are well ventilated, but they've got a blood clot. They have a pulmonary embolism that has come past and is now occluding that vessel. So think about what happens. The blood flow is now stopped. Now, of this blood flow that stopped, remember, this ventilation is fine. So this blood flow stops, which now means that the oxygen cannot jump into the blood because there's no blood to exchange with. The CO2, well, cannot jump out of the blood. So all that's happening is air is going in, out, in, out, in, out. Now if that continues to happen, these values start to look more like the values in the atmosphere because nothing's been exchanged, right? So as you breathe in, out, in, out, in, out, what you'll find is that the oxygen is no longer 100, it starts to shift its way to 159, let's just say 150 because it's not going to be exactly, and the carbon dioxide shifts down to nearly zero, so virtually 0.2 millimeters of mercury. So what has happened? You've had an increase in oxygen, but you've had a drastic decrease in CO2, and this is because of the occlusion. So what you'll find is, this point now, is that so that's the first point. Second point is that a drop in perfusion resulted in a drop in alveolar CO2. Let's change colours so that you don't get it confused with this one. A drop in perfusion because of the clot resulted in a drop in alveolar CO2, and this results in, how are we going to match it? This is dropped. What do we want to do? We want to drop this. So we want to bronchoconstrict. So a drop in alveolar CO2 equals bronchoconstriction, which equals a drop in ventilation. Okay? So, what are the major points? What's the take-home point? The take-home, two take-home points. First take-home point is ventilation wants to match perfusion, and perfusion wants to match ventilation, because then you get an adequate amount of oxygen in your blood that can be delivered to tissues and get rid of an adequate amount of CO2 via expiration. If you have some sort of problem that's obstructing your airways or obstructing your blood flow, your body responds, your lungs respond to try and make it match. And overall, you'll find that a drop in ventilation will result in a drop in perfusion. The drop in ventilation will result in a drop in oxygen in the alveolar. This drop in oxygen in the alveolar results in vasoconstriction. Next point is, if there's a drop in perfusion, we want to get a drop in ventilation. Okay? And that the drop in ventilation results in a drop in carbon dioxide. This results in bronchoconstriction. So, CO2 is responsible for changing the diameter of the airways, and O2 is responsible for changing the diameter of the blood vessels. I'm sorry that took so long, but I hope that makes sense.
Hi everybody, Dr. Mike here. In this video we're going to take a look at gas transport, the movement of oxygen and carbon dioxide around the body, picking up oxygen at the lungs, which we've got here, and dropping it off at the tissues. But at the same time, we're throwing out carbon dioxide at the lungs and picking it up at the tissues. When we look at gas transport, it's simply the fact that the circulatory system, the respiratory system, and the tissues of the body are intimately related. Gas needs to go back and forth between all of these particular structures. Now, the transport of these gases are occurring in the blood, and specifically at the red blood cell as well. So not just the blood plasma, but the red blood cell too. And so what we need to do is we need to draw up a red blood cell, and I think the best place to start is actually at the tissues. What's happening at the tissues, and then we'll look at what's happening at the lungs. So let's draw up a nice big red blood cell. and see what's happening at the tissue. So remember, first of all, we want to throw oxygen from the blood to the tissues, and we want to pick up carbon dioxide from the tissues and put it into the blood. All right. So first thing is, I think let's start with carbon dioxide. That's what we are picking up here at the tissue. So first thing with carbon dioxide is that it can simply be transported in the blood plasma itself. Not even with the red blood cell. That carbon dioxide can go straight into the plasma and just be dissolved directly in the plasma. So the carbon dioxide can be dissolved directly in the plasma. Second thing is that the carbon dioxide can go into the plasma, but it can bind with water in the plasma. Now, if carbon dioxide binds with water in the plasma, it's a simple maths equation. What we get is H2, because there's the 2H, C, there's the C, O, and how many do we have? 2 there, 1 there. So that's 3. And that's called carbonic acid. So carbon dioxide binds with water, producing carbonic acid in the plasma. But as we know, carbonic acid hates itself, splits itself apart. And what it forms is bicarbonate and hydrogen ions. Now what happens is the hydrogen ions will bind to plasma proteins to buffer out the hydrogen ions, because we know that all pH is the amount of hydrogen ions. If there's too many of these free floating in the blood, for example, it's going to be too acidic, not good for our body. It needs to be buffered out, right? And so if it's in the plasma, proteins can do this. So there's 2 ways that carbon dioxide can be transported. This equation can happen inside the red blood cell as well. Now here's the thing, when it happens outside the red blood cell, it's actually a very slow reaction. Now the reason why it's a slow reaction is because there's no enzymes out here to help speed it up. But if this reaction happens inside the red blood cell, for example, so CO2 moves into the red blood cell, it binds with water, it produces carbonic acid, which is H2CO3, which then splits itself apart into bicarbonate, HCO3 negative. Let's swap it around just to make it easier, and I'll show you why in a sec. Hydrogen ions and bicarbonate. So that's the same thing, doesn't matter which way that you write it. What we now have is the whole reaction happening in the red blood cell, but it's fast. Now, it's fast because there's an enzyme that helps this called carbonic anhydrase. Carbonic anhydrase. And it speeds this reaction up. In actual fact, this is the most abundant way, or this is the main way that carbon dioxide is actually transported in the red blood cell by turning into bicarbonate. So you can see, where is that CO2? It's sitting here in the bicarbonate. So you could say that carbon dioxide is transported as bicarbonate. So dissolved in plasma and as bicarbonate. But there's another way. Carbon dioxide, when it gets into the red blood cell, can actually just bind straight to hemoglobin, which we can write as HB, like that. And what we have is carbaminohemoglobin, that's what it's called. So there's HB, CO2. Like I said, it's called carbamino, maybe we'll write that down. No, we'll leave it, yeah, we'll write it down here. Carb, amino, hemoglobin. Now the reason why it's called that is because the carbon dioxide doesn't bind to the heme portion like oxygen does, we'll see in a sec. It binds to the amino acid portion, the globin portion. That's why it's called carb for carbon dioxide, aminohemoglobin. All right? Okay, next thing is what's happening with oxygen. So this is, even though there's 4 ways here, in actual fact there's only 3 particular ways. 1, dissolved in plasma. 2, transported as bicarbonate, either outside the cell, slow, or inside the cell, fast. Number 3 is bound to hemoglobin, specifically the globin portion. What about oxygen? Well, we know that oxygen is going to be in the red blood cell and we need to get it out to the tissues. So what we've got, for example, is we've got oxygen bound to hemoglobin. Right? This oxygen is bound to hemoglobin. But what we need to do is we need to disassociate that oxygen from the hemoglobin. And so we need to give up that hemoglobin and we need to give up that oxygen. And what we now can do is get that oxygen out and send it to the tissues. So that's one way that, that oxygen is transported, bound to hemoglobin. The other way is oxygen can simply, like carbon dioxide, be dissolved in the plasma. Dissolved in plasma. And it just diffuses out. So there's only two ways. So there's three ways for carbon dioxide to be transported, only two ways for oxygen to be transported. Now, an important point here. What tells the oxygen to disassociate from the hemoglobin? How does it know it's at the tissues and it's time to jump off and deliver itself to the tissues? Well, this hydrogen ion. What happens is that this hydrogen ion will force the hemoglobin to disassociate from the oxygen, because what the hydrogen ion wants to do is it wants to bind to the hemoglobin to form a deoxyhemoglobin. And the reason why this is important, because again, hydrogen ion needs to be buffered. You can't just have free-floating hydrogen ion, or at least not too much. It needs to be buffered. So the hemoglobin can do this outside the cell. Plasma proteins can do it inside the cell. Hemoglobin can do it. Really important. Another important point here is that the bicarbonate isn't just floating in the red blood cell. That bicarbonate needs to get out. This bicarbonate can stay out in the plasma, but this also needs to get out into the plasma. So what happens is this bicarbonate needs to come across a transport channel in the red blood cell, and it will be transported out into the plasma, and it will be exchanged with chloride. So you get a shift of chloride into the cell, and this is called the chloride shift. So what you can see is this is how carbon dioxide jumps from the tissues into the red blood cell or the plasma for transport, and how the oxygen goes in the opposite direction. Now, this whole process just happens in reverse when we get to the lungs. And so, for example, what we can do is draw up another red blood cell. And we can have a look. So let's start with carbon dioxide again. The carbon dioxide that's just dissolved in the plasma needs to get out to the lungs so we can breathe it out. So it just diffuses out. Easy peasy. What about the carbon dioxide that's stored, or transported I should say, as bicarbonate? Well, what happens here is that the hydrogen ions will bind to the bicarbonate. That will form carbonic acid, H2CO3. That then will disassociate into carbon dioxide and water. And then the carbon dioxide will diffuse out across the lung tissue at the alveoli. What about inside the cell? Same thing that's happening inside the cell, but remember, the bicarbonate is sitting outside the cell, so we need to do that chloride shift in the opposite direction. So we need to get the bicarbonate that's sitting outside the cell now, and we need to swap it and throw it inside the cell, HCO3 negative. Swap it with that chloride. Now this bicarbonate combined with the hydrogen ion, it can form H2CO3, carbonic acid. That can then split itself apart into water and carbon dioxide, and then that carbon dioxide can diffuse out. And again, carbonic anhydrase can help with this process. And again, it is fast. So this is a fast way of doing it, and this is the slow way of doing it. In saying that, because it's fast, more of carbon dioxide can be transported in this way compared to the way it's transported outside of the cell. Okay, now, that's the carbon dioxide, but remember we've also got carbon dioxide bound to hemoglobin as well. So we've got the hemoglobin bound to carbon dioxide. That needs to split itself apart. So we've got deoxyhemoglobin and carbon dioxide, and then we'll chuck that carbon dioxide out. Now what about the oxygen? Well, I said to you earlier that oxygen can be transported, dissolved outside, or that carbon dioxide can jump in, oxygen can jump in and bind to hemoglobin. Now, this is the thing. There's free hemoglobin because the carbon dioxide's going out. There's also free hemoglobin because the hydrogen that we got here is now reversibly, remember, it was bound to hemoglobin. And that hydrogen jumped off. Now we've got free hemoglobin, and this is the hemoglobin that the oxygen can use to bind to. And now we've got oxygen bound to hemoglobin. So, take home message, carbon dioxide is transported 3 ways. Let's write this down, really important. Carbon dioxide can be transported 3 ways. 1, it can be dissolved, and this is around about 10% of carbon dioxide is dissolved and transported this way. Number 2, it can be bound to hemoglobin. What you'll find is this is around about 20% of carbon dioxide is transported that way. And number 3 is that carbon dioxide can be transported as HCO3 negative, which is bicarbonate, and this is by far the most abundant way, and that's 70%. Now let's compare this to oxygen, right? So I'll just get rid of this for a second. Let's now compare this to oxygen, which I said can only be transported 2 ways. 1, dissolved. 2, bound to hemoglobin. Now what you're going to find is this. Bound to hemoglobin, it's around about 98%, even more. So for example, you could say bound to hemoglobin is transported around about 98, 99% and dissolved around about 1 to 2%. Now you may think, if only 1 to 2% of oxygen is dissolved, but 10% of carbon dioxide is dissolved, why? Shouldn't it be comparable? No, carbon dioxide is easier to dissolve. So it's easier to pass through barriers and dissolve in fluid, specifically in blood plasma. So this is important. This is the main process of gas transport around the body. Thank you. Buffers resist drastic changes in pH. We know that our blood has a pH of between 7.35 and 7.45. That's worth putting up. pH of 7.35 to 7.45. And if the blood pH goes below 7.35, it's becoming too acidic. If it goes above, it's becoming too alkalinic. That means that the concentration of hydrogen ions, which dictates the pH, is either going to be too much if it goes in this direction, too many hydrogen ions, or not enough hydrogen ions if it goes in this direction. So what happens in the body is if we don't have enough hydrogen ions, we need to make more. If we do have too many hydrogen ions, we need to reduce it. And this is what buffers do. They resist these drastic changes in pH. All right, so for example, I want to talk about a quick buffer, and a buffer that looks like this. H2CO3. What this is called is carbonic acid. And you should know that the definition of an acid is anything that can donate a hydrogen ion. So that means that this carbonic acid can give us a hydrogen ion. Now if it does give us a hydrogen ion, what are we left with if we take 1 hydrogen out of this? We're left with 1 hydrogen, 1 carbon and 3 oxygen, which is HCO3. And because we stole a positive from this, it's left with a negative, and this is called bicarbonate ion. Bicarbonate ion. And this is our hydrogen ion. Again, it's the concentration of the hydrogen ion that dictates the pH. So what we've got here is this. A weak acid which donates a small number of hydrogen ions and leaves us with a weak base. Now the definition of a base is something that can mop up hydrogen ions. It can bind to hydrogen ions, which means if that can bind to that, this is a reversible equation. And so this can also go in this direction. Now what we have here is a very simplistic buffer system, where if we don't have enough hydrogen ions, the weak acid will split apart and release hydrogen ions. If we've got too many, it will bind to bicarbonate and go in that direction. Now, our body utilizes this reaction, but with the addition of some other parts. For example, carbon dioxide and water. If you bind carbon dioxide and water, have a look. There's one carbon, there's the one carbon. 2 plus 1 oxygen is 3 oxygen, 2 hydrogen, 2 hydrogen. If you bind carbon dioxide with water, you get carbonic acid. So let's write these down just for completion's sake. Carbon dioxide and water. All right. And that can split itself apart to produce these two. So that's reversible as well. What we've now drawn up here is something called the bicarbonate buffering system. And this is one of the most important biological buffers that we have. Now let me talk about it in regards to how it actually works. All right. This end of the equation deals with the lungs. This end of the equation deals with predominantly the kidneys. Now this is important because when we look at imbalances in regards to pH, we can say if something's wrong here, it could be metabolic or kidney caused. If something's wrong here, then it could be respiratory caused. And this is going to be the basis of respiratory versus metabolic acidosis or alkalosis, right? That's for another lecture. But let's think about it like this. Let's just say we do not have enough hydrogen ions in the body. If we don't have enough hydrogen ions, the pH is going up, right? So remember, it's a reverse logarithmic equation. Have a look at my previous video about calculating pH, right? We don't have enough hydrogen ions. How do we create more? Let's have a look. Carbon dioxide. This is a byproduct of respiration. Breathe in oxygen. Our mitochondria utilize that oxygen and it produces ATP, water, and carbon dioxide. And we don't like carbon dioxide, we want to breathe it out. But in order to go from the cells to our lungs to breathe out, it has to go in our bloodstream. So when carbon dioxide hops in our bloodstream, most of our bloodstream's water. Inevitably, all our carbon dioxide is going to be binding to that water and it will be producing carbonic acid. But because carbonic acid is a weak acid, hates itself, splits itself apart and produces hydrogen ions, which means one way we can increase the concentration of hydrogen ions in our body is through the accumulation of CO2. How can we accumulate CO2? I'll show you. Hold your breath. If you're holding your breath, you're not breathing out. And this is what happens. Some individuals who do not have a high enough concentration of hydrogen ions in their blood, they may be holding their breath a little bit. Their breathing will be different. Let's think of it flipped. What if we have too many hydrogen ions? Well, if we have too many, the bicarbonate will mop it up and produce carbonic acid, which will then split up and produce water and carbon dioxide. So if we are acidic and our pH is too low because we have too many hydrogen ions, we end up producing more carbon dioxide, which means the patient may breathe more. So the respiration can be an indication of the blood pH. And you can also see if we don't have enough hydrogen ions, it goes in this direction. If we have too many, it goes in this. And this is the bicarbonate buffering system.